So thank you very much to Helton for the invitation, and I'm sorry I can't be with you in person to give the talk. So I'm going to talk about the investigation management of thyroid eye disease, and I'm going to cover these topics. First of all, the basics to management of the thyroid and the patient during thyroid eye disease, then a bit about diagnosis, because not all cases are clear-cut, and then how to treat mild, moderate and severe eye disease, with the emphasis on the mild and inflammatory diseases, because this is what we see the most of. So the basics are smoking cessation is key. People who smoke cigarettes have a 4 times risk of Graves' orbitopathy, and numerous studies show worse outcomes of all treatments for people who smoke. So it's imperative people give up smoking in this situation. With regards to thyroid management, it's really important to make the patient euthyroid and keep them euthyroid. Often these patients have the most aggressive Graves' disease, the most aggressive hypothyroidism, and so we often use a block and replace regimen, and we measure free T3 regularly and keep it in the reference range. It's quite common for these people to need higher doses of antithyroid drugs than normal to keep the free T3 in the reference range, and it's important that this is normalized. In patients with active thyroid eye disease, we avoid radioiodine because that can worsen disease. And of course, if we give radioiodine to someone with inactive disease, it's important to avoid hypothyroidism. This just shows you this classic paper from nearly 30 years ago now, showing that if you treat the patients with antithyroid drugs, about 5% of their eye disease will worsen. It's about the same with surgery, but with radioiodine it's up to 15%. So we avoid radioiodine in people with established eye disease that's active, or people who we think are at high risk of eye disease. So that's all easy stuff. Making a positive diagnosis isn't always helpful, isn't always easy, because we're unhelpfully trained as endocrinologists and not as ophthalmologists. And so in the eye clinic, we do get patients who create a diagnostic dilemma. So I'm just going to talk you through these things in a few slides. So if the patient has current or past autoimmune thyroid disease, that's obviously a clear pointer. Positive TRAb antibodies. And then upper eyelid retraction is a really invariable feature. So if someone doesn't have upper eyelid retraction, we start to be concerned that the diagnosis might be wrong, particularly if they're not particularly inflamed. And then medial or inferior rectus involvement is the typical pattern of eye muscle disease. So eyelid retraction, this shows a lady with really marked upper eyelid retraction in the right eye compared to the left, which is normal, but her lower eyelid is in the normal position in both eyes. It's just overlapping the bottom of the iris, the bottom of the cornea, by 1 or 2 millimeters, and that's normal. So upper lid retraction is a really pathognomonic sign for thyroid eye disease, whereas lower lid retraction means proptosis. The eyes are pushed forward, and the pushing forward of the eyeball means the lower lid is pushed down. So this lady has both upper eyelid retraction and lower eyelid retraction. So she has bilateral proptosis, whereas this woman, this eye probably isn't proptosed. I need to take a measurement to be sure, but the lower eyelid position looks very symmetrical, so it's unlikely to be proptosis. And so this is a really helpful little pointer when we're assessing patients. Another sign that we really see, we call lateral flare of the palpebral aperture. So if you draw a line vertically through the pupil in a normal eye, you'll see the same amount of white on the medial side as on the lateral side, but in thyroid eye disease you see this really flaring of the apex of the palpebral aperture laterally, giving you a lot more white on that side and on this side. And of course this gives exposure and dryness to the eye, which is why people complaining of gritty eyes and tearing. This just shows you the medial and inferior rectus enlargement, really quite marked compared to the lateral rectus, and this eye is relatively normal as well. So this is a typical scan for thyroid eye disease. So when to order a CT scan? So really, if there's cases of diagnostic uncertainty, but that's really lack of upper eyelid retraction. It gives us diagnostic uncertainty, unilateral proptosis. If there's no thyroid history, normal anti-TSH receptor antibodies, normal thyroid function. Of course, the medial rectus is most typically involved, which gives you a convergent squint. If the squint is divergent, that suggests the lateral rectus may be involved, and so we normally scan people with divergent squints. Also, if we have suspected dysthyroid optic neuropathy, we'll scan someone, and also prior to decompression surgery to look at the bones. But these are the diagnostic reasons. So we can describe the natural history of thyroid eye disease by this Rundle's curve. And Rundle really described a period of worsening severity of the eye disease, followed by a plateau phase, which may be short-lived or lasts for up to 6 months, and then a gradual improvement, but notably not getting back to normal after the disease. And so we have a period when the severity of the eye disease is worsening, when it's active or inflammatory. And in this active or inflammatory stage, the disease is amenable to medical therapy, because the idea is if we intervene in this active inflammatory phase, we can lower the severity and that will improve the outcome for the patient. Pardon me. In the phase when the disease is inactive and maybe spontaneously improving, but still left with some residual eyelid deformity or proptosis or squint, then the eye disease is amenable to rehabilitative surgery. If you try to give anti-inflammatory treatments in this stage, they're not going to work because the person's eyes aren't inflamed. So it's important to look at this pattern and bear in mind most patients are active for a year, perhaps 18 months, but rarely longer than that. And we judge activity by the clinical activity score, and this looks like a big long list of things, but it's basically 2 subjective complaints: do you get pain spontaneously or when you move your eyes from side to side? 2 eyelid signs, swelling and erythema, then 2 conjunctival signs, swelling, conjunctival edema or chemosis, and redness, again erythema. And then a bonus one is inflammation of the caruncle or plica, the little pip in the medial corner of the eye. So this is clinical activity score, and we use this every day to decide whether someone has active inflammatory disease, which we would arbitrarily define as a clinical activity score of 3 or more, or their disease is by and large inactive, which is 2 or less. So the European Group on Graves' Orbitopathy, defines 3 different classes of eye disease. Mild Graves' Orbitopathy just has a minor impact on quality of life, insufficient to justify the risks of immunosuppression or surgery. Moderate to severe, it's not sight-threatening, but it does impact quality of life, and that justifies the risk of immunosuppression or surgery. And then sight-threatening, which is optic neuropathy or corneal breakdown, and then we need to intervene immediately. So for most of the rest of my talk, I'm going to go through these 3 steps and describe what treatments and what assessment we do. So first of all, mild Graves' Orbitopathy. It doesn't justify immunosuppression or surgical intervention. So patients with mild disease complain of soreness of their eyes, grittiness of their eyes, watering, a change in appearance. Particularly young women are very sensitive to changes in appearance in their eyes, eyelid redness or eyelid edema, conjunctival redness and edema, proptosis or exophthalmos, so the eye may be pushed forward a little bit in more severe cases, but not diplopia. Diplopia takes it into the next category of being moderate or severe. So upper eyelid retraction, very subtle in this patient, probably 1 or 2 millimeter upper eyelid retraction in the right eye here compared to the left, but that's enough for some people to complain about it, and even though we know there's not much to be done about this, patients are often concerned about this. More severe upper eyelid retraction, you can see here's a good 5 millimeters there, and this would clearly warrant some assessment and treatment. And then this lady's got eyelid swelling, and she's got quite a bit of lower lid retraction here, so that indicates she's basically got bilateral proptosis, although it's quite symmetrical eyelid swelling there as well. Quite erythematous on the conjunctiva and in the plica there as well. So we treat this with symptomatic measures, artificial tears, hypomelos, viscotears, or Celluvisc, and then we often give people a protective jelly to put in their eyes at bedtime. In the UK it's called Lacrylube or Xalin, and this makes their eyes more comfortable in the morning. We also consider recommending selenium supplementation, up to 200 micrograms daily. Interestingly, selenium is very strongly enriched in Brazil nuts. So in fact, we often ask our patients to eat Brazil nuts because they're cheaper than buying the selenium from the pharmacy. So why do we do that? So the UGOGO group did a nice randomized controlled trial looking at selenium, which is an antioxidant to dampen down the inflammation in mild Graves' orbitopathy. So this just shows you the benefits. Three things: improved, no change, or worse. And this is at 6 months. So this is the overall eye score. More people with selenium improved than the placebo, and in the placebo, more people worsened than in the selenium group. So selenium is effective, and this is the subjective quality of life score. The patients liked it. 75% felt their eyes had improved, compared to just about 40% in the placebo group, and a lot more people in the placebo group worsening their quality of life. So this is an important piece of work. Selenium has virtually no side effects, and it's as much to ask the patient to take 1 or 2 Brazil nuts a day. So that's mild active disease. This is the commonest presentation we see. Probably 75% of all eye diseases in this category. And I would say take this seriously and examine the patient's eyes, because in the thyroid clinic, patients will say, "Doctor, my eyes are abnormal," and the patient isn't aware that you've assessed their eyes while they're talking to you. So all the time they're talking to you, you're taking the history, you're looking at their eyes and you're assessing their eye disease, but the patients don't realise that. And so patients often feel ignored when that you then examine their thyroid, but you don't look at their eyes. So I would say take 1 minute and examine their eyes, get them to look upwards and downwards to look for lid lag, or look for conjunctival edema, chemosis, for instance, and then at least the patients know their eyes have been taken seriously, and that's often enough to make them feel better. Of course, the simple things, get them to stop smoking, make them euthyroid, use the eye drops, and then selenium supplementation. The randomized controlled trial shows that is effective. So moving on now to more moderate to severe Graves' disease. So this is Graves' disease that is not sight-threatening, but does impact quality of life to justify immunosuppression. So moderate or severe disease, the symptoms are the same for mild disease, but eye discomfort, ache behind the eyes is quite typical. Sometimes people describe this as a tightness, double vision, diplopia, first thing in the morning typically, and then it often goes away for the day until late in the evening. Often what the patients say they can't watch television because they get double vision in the evening trying to watch television. Severe change in appearance, and as I said, sufficient to affect the quality of life. So lots of lateral flare in this lady, lower lid retraction, so proptosis, upper lid retraction, lots of eyelid edema, some chemosis there, and some inflammation of the plica there as well. So this lady is quite active and is quite disfigured by this eye disease, so we would consider this for treatment, even though she doesn't quite have diplopia as judged by this picture anyway. And obviously more degrees of chemosis here, conjunctival inflammation, severe eyelid edema and erythema there, and once again some injection in the plica and laterally. And this is a more severe case with more eyelid erythema being more striking. So we use several different treatments for moderate to severe disease, but if the disease is active, glucocorticoids are very good at damping down inflammation, and if motility is the chief problem, we often give glucocorticoids followed by orbital radiotherapy. And then there are these other treatments that I'll talk about: mycophenolate, rituximab, teprotumumab, and tocilizumab, also there is some evidence for. So glucocorticoids are really the workhorse of our armamentarium for active inflammatory thyroid eye disease. So we tend to use IV steroids because they have a better effect than oral with fewer side effects. And we give this protocol. They have 6 by 500 milligrams of methylprednisolone once a week for 6 weeks. Then we see them, assess the response, and if the response has been good and the side effects are low, we then go and give them another 6 doses of 250 milligrams for the next 6 weeks. So it's a 12-week course. They receive 4.5 grams of methylprednisolone over the 12 weeks, and that's normally good enough to get most patients either inactive or close to being fully inactive. If you want to use oral, it's 1 milligram per kilogram per day and then reduce, but I'll show you why we don't use oral. And 80% of patients will have an objective and symptomatic response to IV steroids. So this just shows you the comparison of intravenous steroids, the protocol I've just shown you, versus oral. So you probably get about 75% of responders to IV steroids, as compared to about 50% with oral, but the side effects of IV steroids are a lot less, only about 15% as compared to about 50% with oral steroids. So there are big advantages to giving IV steroids. It feels inconvenient. You have to bring the patient to the hospital for 1 hour a week to have the infusions, but in terms of a 20% better relapse remission rate or improvement and less side effects, we think that's worth it. So they're not efficacious in all. Patients do have side effects: weight gain, mood disturbance. About 20% develop type 2 diabetes, and there are other problems. If you give too much, our normal regimen is 4.5 grams, but if you get up to 8 or 9 grams of methylprednisolone, then you can get hepatic necrosis as a consequence of that. So you do have to keep a tag on how much IV steroid you're giving. So orbital radiotherapy is our next treatment. It's not very good for inflammation, and it doesn't work very quickly, but it's good for motility problems, people with diplopia, particularly in older patients. So 20 grays are given over 10 days. There's a 50 to 80% response, but it's a slow response over 6 to 12 months. The motility and the double vision improves. It's contraindicated in patients with diabetes or other forms of retinal vascular disease. We don't use it in patients under 40 because we feel they're too young, and it's most effective if used with prednisone. So we give 20 milligrams of oral prednisolone for the 2 weeks of the orbital radiotherapy. So several studies have shown a good effect of orbital radiotherapy, 60 to 80% response rate, but the study from the Mayo Clinic by Gorman and also a most recent study by Taylor, the CERTED study, didn't show any benefits of radiotherapy. So it's not uniform how it works, but we do feel it's effective for many of our patients. So rituximab, if you like, is the new kid on the block. This is a chimeric anti-CD20 monoclonal antibody, and it's a B lymphocyte depleting antibody. It binds onto this B cell receptor, and it wipes out the B cells really as it's been given. So you get reduced plasma cell formation and reduced antibodies, and it's good for lots of autoimmune diseases. And our experience now in thyroid eye disease is that 1 dose is sufficient for almost everyone. So these are the case series investigating rituximab before the randomized trials were published. So 9 series, a total of 43 patients, and 39 improved. So it's a 91% improvement with rituximab. This shows you that there are 2 randomized trials, and strangely they show different effects. When compared to methylprednisolone, this was the Italian study. This is the rituximab with the dark line. People go into remission. Their CAS score, clinical activity score, drops by 2 points by 12 weeks and 3 points by 6 months, and they stay in remission. The drop rate is actually very similar to methylprednisolone, apart from at the end of 12 weeks, when you stop the 12-week course of methylprednisolone, a few people relapse and get worse for a while, whereas everyone with rituximab stays in remission. So this just shows you rituximab, are they clinically active or not? 100% inactive at 6 months, as compared to about 60% who had intravenous steroids. So the European study shows this is better. The American study from the Mayo Clinic Stan showed no difference between rituximab and placebo, and the only real difference in these studies were the European study took patients within an average of about 4 months of being diagnosed with thyroid eye disease, whereas the American study took patients a lot further on. They were an average of 9 months further since diagnosis. So rituximab is most effective in patients treated early on in their disease course. And of course, this patient didn't have moderate to severe eye disease. She had sight-threatening eye disease, but this was just an example of a patient we couldn't operate on Christmas Eve when she presented because the operating theatres were all closed, and so we gave her steroids and rituximab, and actually when we assessed her the day after Christmas, her eyes were much better, and this is the result of methylprednisone and 2 doses of rituximab by Easter, and this is with no surgery. This is a case of severe eye disease that got better with methylprednisone and rituximab alone. So the logistics, one 500 milligram dose is sufficient, and that costs about £800 in the UK. About 50% of people get an infusion reaction, flu-like symptoms, fever, hypotension, and we pre-treat people with methylprednisone, antihistamine, paracetamol. Screen for hepatitis B before administration because there are cases of fatal reactivation of hepatitis B. We've seen 1 case of late onset neutropenia which improved, and then there's a small risk of infection. That's just standard infections, it's not atypical infections, urine infections, pneumonia, etc. So it's a low risk, and we've actually been lucky not to see much of that. This year, the study's been published about teprotumumab. This is a phase 3 study, and prior to that there's a phase 2 study, both published in the New England Journal of Medicine. So I'm going to talk about teprotumumab now, which there's a lot of fuss about. So the TSH receptor in the thyroid, in the orbital fibroblast, signals in conjunction with the IGF-1 receptor, and they share a common arrestin, the beta-arrestin molecule, which appear to give this crosstalk. And so IGF-1 receptor is probably important in the pathogenesis of fibroblast proliferation and eye disease. And so teprotumumab is an antibody that knocks out the IGF-1 receptor signaling. So this just shows you the summary of these 2 studies together. So this is a response rate. About 60% have responded by 6 months compared to 20% in placebo group. These are modest numbers, 80 in each group. This just shows you the clinical activity score. So teprotumumab is very effective in reducing clinical activity by 4 points, but probably not much different to steroids, to be fair. Whereas what is really different to steroids is the proptosis reduction, because with steroids we don't see much in the way of proptosis reduction, perhaps a millimetre or so, whereas with teprotumumab you get this rather large 3 millimetre reduction in proptosis in these patients. Also, the quality of life index goes up with teprotumumab as well, so patients also are happy with the result of that. The problem is there are some side effects of teprotumumab. This is the tepro in blue compared to placebo. So muscle spasms are increased, nausea, alopecia, and then there are these 2 ones that don't occur in the placebo group: hearing problems, abnormal taste, dry skin. So I'm going to just mention about the hearing problem because people have had transient or more lasting deafness following teprotumumab, and this turns out to be based on some biology because the IGF-1 knockout mouse has reduced sensitivity to hearing. This shows you the heterozygous loses a couple of tones, but the homozygous IGF-1 knockout mouse loses 4 scales. And remember, the decibel scale is an exponential logarithmic scale, so this mouse is pretty deaf, and this shows you again that it turns out IGF-1 is important for hearing. So in the UK we can't afford to use this drug at the moment, but this is definitely something to be wary of. So teprotumumab is also eye-wateringly expensive. So it's an 8 8 doses are given. The first dose is smaller, 10 milligrams per kilogram, then the next 7 doses are 20 milligrams per kilogram, and it's given every 3 weeks or so. So for the 8-dose course of the treatment, if you're 50 kilograms, it costs $225,000. Going up to, if you're 100 kilograms, it costs $450,000. So this is really an incredibly expensive treatment. The NHS in the UK is unlikely to be able to afford this for significant numbers of patients. And there are lots of unknowns. Are smaller doses equally effective? Are shorter courses equally effective? It's unlikely the drug company will fund research into doing this, so it's going to be down to the community to work out whether we can use teprotumumab at more reasonable doses. So these are the immunotherapy options. Methylprednisone is really good for inflammation. It's not so good for proptosis. It's good for optic neuropathy, and it's really safe. There are millions of people who have received this drug. Rituximab, now also millions of people have received rituximab for rheumatoid arthritis and lymphoma, so the safety profile is good. There are 1 or 2 side effects, and 50% of people will feel poorly during the thing, but it's generally good. There's some question in patients with optic neuropathy because 1 or 2 patients have had worsening optic neuropathy following rituximab. Mycophenolate mofetil is another thing we use, but these are all fairly cheap options. Methylprednisone, your full course of 12 infusions, less than £100. Rituximab is about £800. Mycophenolate's about £200 a month, so it's actually quite a bit expensive. Teprotumumab, in contrast, seems really good, but the trials show about 90 patients treated with teprotumumab. Before this, there's data from a few hundred cancer patients treated with IGF-1 receptor antagonism, but in the longer term, we don't really have a good handle on the safety. Tocilizumab, there's some data from Spain about the use of this as well, and this is also used more in rheumatology conditions, and so there's more of a safety record there. So in our clinic, methylprednisone is our first choice, and we use a lot of this. Rituximab our second choice, and then mycophenolate mofetil is our third choice of treatment for patients who have often had a much longer disease course and they've had rituximab and failed it, or for some reason rituximab isn't appropriate for them. So the plan is moderate to severe and active eye disease. Methylprednisone either inactivates them and then it's rehabilitative surgery, but they're not inactive or there's only a partial response. Rituximab, mycophenolate, orbital radiotherapy are things we think about. We can go on to more steroids as well, but we tend to not do that after the 12 doses. So that's the 4.5 grams over 12 weeks, and our first reactions will be either rituximab, or if there's a lot of motility problems, orbital radiotherapy. So to finish off with, I'm going to talk about sight-threatening disease. So this is dysthyroid optic neuropathy or corneal breakdown, and we need to intervene immediately in this case. This just shows you the guy with really congested eyes, and you can see he's got double vision because he can't move his eyes. So this is optic nerve compression. The patient complains of retrobulbar pain, tightness or a hard eyeball, or just sometimes loss of vision. So in the clinic, we can pick this up as 4 clinical signs: decreased visual acuity, decreased colour vision, an afferent pupillary defect, and swollen optic disc. So these are all things you don't need to be an ophthalmologist to be able to elicit these signs. Proptosis is not necessarily a feature because in fact it's the pressure building up behind the eyeball and the eyeball not moving forward that gives you the pressure on the optic nerve. And patients, East Asian, Japanese and Chinese patients may be more prone to optic neuropathy without gross signs because their eyeballs are limited by the shape of the orbit in moving forward. So management must involve an ophthalmologist. We give immediate IV methylprednisone, 3 by 500 milligrams or 3 by 1 grams on day 1, 2 and 3. Not weeks 1, 2 and 3, we give it sequential days. And then if there's a response, then they will go on to further steroids and orbital radiotherapy. If there's no response, orbital decompression surgery. So this is semi-urgent surgery within a week to preserve their optic nerve function. So to finish off, never ignore a Graves patient who mentions their eyes. At least go and look at their eyes properly so they feel they've been listened to and you've examined their eyes. Because this is a big source of dissatisfaction when we see patients in the eye clinic. They say, I've been mentioning my eyes to my doctor for months and they just ignored it. Okay, explain the natural history, the Rundle's curves, that even if we don't do anything, thyroid eye disease does improve with time in everyone. It's just that in some people, the threshold to intervene, their quality of life is sufficiently affected for us to want to do something. And then just another tip, patients with optic neuropathy, dysthyroid optic neuropathy, are often not grossly proptosed. So be alert to dysthyroid optic neuropathy because it doesn't always present with really terrible looking eyes. So this is the summary of the UGOGO Graves orbitopathy guidelines published in 2016. I'm not going to go through this slide, but do have a look at these guidelines because they're very helpful, and the structure of my talk has been based on the guidelines. And I just want to thank my colleagues in the Combined Thyroid Eye Disease Clinic in Newcastle, and thank you for your attention today.